Greetings everyone, this is Tracy Marin, and this presentation is going to be about hemodynamic monitoring. The objectives of this presentation include discuss the basic cardiophysiology in order to understand hemodynamic monitoring, describe the function of an arterial transducer line, A line, and identify the parameters obtained from a pulmonary artery catheter. So let's start with a basic cardiophysio review. The term hemodynamics simply means movement of blood, where hemo means blood and dynamics means movement or in motion. So I'm going to start on the left side of the PowerPoint at the oval that is shaded in blue and red right here. This represents the capillaries, systemic capillaries, whether it be at the bottom of the body or the top of the body. From the capillaries, deoxygenated blood will travel through the veins and eventually wind up in the superior and inferior vena cavas, where blood will passively flow into the right atrium. Now, as it enters the right atrium, it will also begin to flow passively through the tricuspid valve into the right ventricle. As blood flows passively through the right atrium to the right ventricle, eventually the pressure in the right ventricle will exceed that of the right atrium, and that's what causes the closure of this tricuspid valve. Now, at the end of atrial depolarization, the atria actually will contract and push the rest of the blood that was in the atria that didn't passively flow yet into the right ventricles, and that's what we call atrial kick. From there, right ventricular contraction will push blood through the pulmonic semilunar valve into the pulmonary arteries. Now here, the arrows represent deoxygenated blood, hemoglobin that is not oxygenated or oxidized. That iron molecule will take on a cyan color. That's where we get the term cyanosis from. And this pulmonary artery is called an artery, even though it's carrying deoxygenated blood, because a vessel coming off of the heart is an artery. A vessel going towards the heart is a vein. So from the pulmonary artery, the blood will continue to branch through the pulmonary vascular system into the left and the right lung, where gas exchange will occur. Carbon dioxide is being removed or is diffusing from the capillary to the alveoli, and oxygen is diffusing from the alveoli to the capillaries. From there, the blood will travel back through the pulmonary pulmonary vein, and will passively dump into the left atrium. Same process occurs in the left atrium as occurred in the right atrium, as it goes through the mitral valve, or what we call the bicuspid valve, into the left ventricle. I hope I said left atrium. I'm sorry if I said right. Into the left ventricle. And the left ventricular contraction will eject blood through the aortic semilunar valve into the ascending aorta, through the aortic arch, and down the aortic descending aorta and other blood vessels as well, where it can go to tissues and again participate in gas exchange at that level where it's delivering oxygen and picking up carbon dioxide. When we look at the right-sided figure, the blood flow is still the same, but this figure is depicting what pressure changes occur during right versus left heart failure. So if we look at the green arrow in the right ventricle, if the right ventricle is in failure, that means it's having difficulty pushing blood forward. So we either have poor forward flow of blood and or backward flow of blood, or both. And usually we will use terms like pressure instead, because it's really the pressure that's going to be transmitted backwards. When that happens, that pressure is transmitted into the superior vena cava and the inferior vena cava, and eventually into the periphery. And what signs we'll see with right ventricular heart failure are jugular venous distension, hepatomegaly, and pedal edema. An early sign of right heart failure before we experience hypotension is when we put a person in a semivalvular position at about a 30-degree angle and push on their liver, we will see JVD occur. So that's an interesting little fun fact about identifying early right heart failure prior to hypotension occurring. If we look at the left side, the purple arrows are representing where that pressure will be transduced if the left heart is failing. So here again, we have poor forward movement and or backward movement of pressure from the left side of the heart, and it's going to move into the lungs. So the hydrostatic pressure in the pulmonary vessels is going to be increased. That's going to cause pulmonary edema, which we can hear early on as bibasilar crackles. So signs of right heart failure are JVD, increase in JVD, hepatomegaly, pedal edema, and usually hypotension. The signs of left heart failure are pulmonary edema and sometimes hypotension, but not always. People can have normal or high blood pressure and still have left ventricular failure recognized as pulmonary edema due to that backflow of pressure. The term perfusion refers to the rate of blood flow occurring at the capillary level. So when we say somebody has poor perfusion, that means that there's not enough blood flow going to a particular tissue. It could be systemic or it could be local. So for example, if somebody is having myocardial ischemia, that means that there's less blood flow going to the myocardium than there should be. So there's decreased perfusion to that myocardium. Now, without adequate blood pressure, there's not going to be adequate tissue perfusion. And inadequate tissue perfusion to meet metabolic demands is what results in what we call cellular hypoxia. And this ultimately results in metabolic acidosis. So why do we need perfusion? Of course, we understand that nutrients and whatnot are going to be delivered through blood, but very importantly is oxygen. And usually when I ask people, what does oxygen do? They can't really explain it to me. They think it's a nutrient. They'll say you need it to breathe, but really oxygen plays a very important biochemical process in the body. Energy. Oxygen is required for the production of ATP, which is our core energy molecule. So if we look at the left side of this slide, you see the term glucose at the top of this picture. And glucose is the key molecule for the creation of ATP. So glucose is going to go through the process of glycolysis. And during that process of glycolysis, it's going to break down into two molecules called pyruvate. And ideally, pyruvate will enter the TCA cycle, or the citric acid cycle. And in the citric acid cycle, there's going to be energy produced. There's energy produced during the glycolysis cycle too. And there's also going to be carbon dioxide produced. Now, the electron passing and the energy produced during the TCA cycle is going to be used to move this reaction into the oxidative phosphorylation cycle. And this is where most of the ATP is going to be produced, a lot of it. You guys probably learned this in biology. Now, one of the byproducts of ATP production is hydrogen. Hydrogen ions are the acid. I mean, they are the definition of an acid. Can something donate a hydrogen ion, then it's an acid. And hydrogen ion, being an acid, needs a neutralizer. Well, oxygen is that neutralizer. So it's going to bind to hydrogen ions to produce water. So the reduction reaction actually in this situation yielding water is 1/2 of an O2 molecule plus 2 hydrogen molecules that will lead to water. If this does not happen, then metabolism slows down. And the reason it slows down is because we're going to convert metabolism into something that's not as productive. And I'll talk about that in the next slide. But in this situation, if oxygen's not there to bind to those hydrogen ions, where are they going to go? Well, they're going to go into many different places. But I want you to pay attention to the equation at the top of this figure. water, H2O, plus carbon dioxide is converted to carbonic acid, which is H2O3, which is broken down into hydrogen ions and bicarbonate. Now, I think you guys learned this last semester. But this is the buffer equation. This is what we use to think about how is acid-base being regulated. It's one of the buffer equations anyway. So in this situation, as hydrogen ions go up, you're going to see bicarb go down because it has to combine to those hydrogen ions to produce carbonic acid, which will break down into carbon dioxide, which will be exhaled, and water, which is also exhaled in sweat and whatever. But when somebody has an acidosis, a metabolic acidosis, you'll notice they become tachypnic. And the reason for that is simple. It's this equation. There's more hydrogen ions. Bicarb is going to bind to it, leading to carbonic acid, breaking down to carbon dioxide and water. How do we get rid of carbon dioxide? We have to exhale it. So you'll notice they'll become tachypnic. So a lot of people think that hypoxemia, decreased oxygen in the blood, is a major cause of tachypnea. But really, that's not the case. Most people won't experience tachypnea as an early sign of hypoxemia. Usually, people who are tachypnic will first be experiencing a metabolic acidosis. Aside from rolling out any sympathetic response and whatnot. But always keep that in mind. So when perfusion is limited, it's not enough to meet metabolic demands. It means we need energy, but we're not providing enough oxygen to be that binder of hydrogen ions. What happens? Well, what happens is, instead of this pyruvate molecule, as you can see here in the middle of the figure, going into the citric acid cycle like it's supposed to, it's going to be moved into what we call the lactic acid cycle. And the byproduct of this process is going to be lactate, which we can measure, and hydrogen ions, which we can also measure, but we usually look at it from a pH standpoint. So when we look at somebody who has sepsis and we wonder, is their perfusion impaired? Are they getting enough tissue perfusion? We might look at their lactate levels, and if they're high, that tells us that they have now, instead of going through aerobic metabolism, which requires oxygen, they converted to anaerobic metabolism, which produces lactate. And in this process of producing energy through the lactate cycle, there will be more hydrogen ions produced. Well, if we go back to this buffer equation, the more hydrogen ions produced, the more bicarbonate needs to be there to bind to it to produce carbonic acid, which will break down into carbon dioxide and water, which will be exhaled. So tachypnea will occur. So when you're looking at an ABG, an arterial blood gas, and you notice that somebody's hypoxemic and their pH is low and their bicarb is low, first think, does this person have a lactic acidosis that's causing the bicarbonate to be low? Because hypoxemia will lead to hypoxia in some situations. Now keep in mind that somebody can be hypoxic, low oxygen in the tissues, but not be hypoxemic. So for example, somebody can have a PaO2 of 100, which is perfect, 100 millimeters of mercury, but their perfusion is very poor to a particular tissue or systemically. In that situation, irrespective of the amount of oxygen they have in their blood, if it's not getting to the tissue will become hypoxic. So let's talk about the determinants of hemodynamics and perfusion. First of all, we have to have adequate cardiac output, which we'll talk about in a little bit. And cardiac output usually is signified by a Q with a dot over the top of it. A dot over the top of a symbol usually means flow rate or a rate of something. In this particular situation, flow rate. Vascular resistance, and that's basically how much the radius of a blood vessel is open or closed, how viscous the blood is, how difficult it is to move blood forward. That is the determinant of resistance. Vascular compliance, how well can the blood vessels expand and accept the volume being injected into them? Vascular elasticity, how well, once that blood vessel has been expanded to accept volume, can it retract back into that resting position so that the blood flow can be propagated? So when you feel your pulse, feel your carotid pulse, every time you feel that pulse, it's not because you feel the heart beating, it's because at the aortic level and the other elastic vessels, as the expansion occurs, that blood vessel retracts back to its resting state and pushes that blood forward. Extra credit question, what is pulse wave velocity and why do we care about that? Another factor we have to consider is circulating volume. If there's not enough volume to circulate, there's not going to be enough perfusion. Viscosity of the blood, how thick is it? The thicker it is, the harder it is to push forward. People who have polycythemia, more red blood cells than normal, will have more viscous blood. People that are hypovolemic will have more viscous blood. And of course, the length of the blood vessel. So all of these can be basically communicated with an equation, Poiseuille's law. And in this equation, the change in pressure is basically the difference between two ends. So in this situation, we can talk about the pressure at the aorta and the pressure at the capillary, where blood flow eventually ends in the point where gas exchange will occur. We can also call this difference in pressure driving pressure. The length of the vessel is represented as L in this equation. The mu is representing dynamic viscosity of the blood, or in any situation of fluid. The Q is representing flow, and in this situation we'll call it cardiac output, or we could also call it perfusion, given that perfusion is actually a flow rate through the capillaries. R is the vessel radius, and A is the vessel cross-section. So in this situation, resistance is increased when the radius is decreased. That's a very important factor to consider, because when somebody has hypertension, it's usually because they either have smooth muscle cell contraction in the arterioles that's causing those blood vessels to be more narrow, or they could also have remodeling that causes those blood vessels to be thicker and less compliant, so they can't expand well. So their basal radius and their expansor radius is lower than normal. Flow rate is determined upon the pressure difference, or that driving pressure, and the resistance. So all of these factors come into play when we're thinking about how well can we get blood flow to the tissue that we need. We have to have adequate driving pressure. We need to make sure that radius is not too tight. We need to open it up potentially. We have to have adequate flow. And the viscosity of the blood should not be too thick. Thick is kind of an exaggerated term. It's never really thick. But those are factors that we need to consider when we're thinking about how well we're perfusing the tissue. Now, we can't talk about hemodynamics, blood flow, perfusion, whatnot, without talking about the autonomic nervous system. So what is the autonomic nervous system? Well, it's a branch of the central nervous system. And on the left side of this figure, you can see that the internal environment inside your body, temperature changes, volume changes, glucose changes, metabolic changes, etc., are going to give off a vibe that's going to produce a signal that is going to be transmitted through the sensory neurons to the brain. And from that, the brain is going to interpret what needs to be done and transfer signals through motor neurons, like smooth muscle cells, neurons that affect smooth muscle cells, etc., to potentially change that internal environment. So, for example, if you need more blood flow, then the motor neurons are going to say, hey, we need to vasodilate. On the other side of that is the somatic nervous system, and this is not as automatic. It is something that is more voluntary, but the same type of thing occurs. If you have an external environment sensation like pain, then that is going to be transmitted to the brain, and this says, hey, there's pain, you need to move or change your position, etc., to improve that external or that internal environment from that external environmental stimulus. There are three branches of the autonomic nervous system. The sympathetic nervous system, which most of you know as fight or flight, which accelerates biological functions necessary to handle stress and increase metabolic demand. And you'll hear me use that term a lot, increase metabolic demand, because really that's what requires an increase in cardiac output, an increase in minute ventilation, an increase in perfusion to tissue so that we can support the development of ATP energy that's required for metabolism. And of course, we need oxygen to do that, as mentioned in the previous slides. On the other side of this is the parasympathetic nervous system, which is the opposite. It's basically the rest and recover or feed and breed part of the sympathetic autonomic nervous system that decreases biological functions when the stress resolves. And then the third one is the enteric nervous system. And this is basically the visceral reflexes of the digestive tract that are involved in digestive functions. For the purpose of this presentation, we will focus on the sympathetic and parasympathetic nervous systems. So if we go back to the sympathetic nervous system, most of the time what we're talking about at the hemodynamic level, we're concerned about the alpha-1 receptor, the beta-1 receptor, and the beta-2 receptor. When we activate the alpha-1 receptor of the sympathetic nervous system, it causes vasoconstriction. When we activate the beta-1 receptor of the sympathetic nervous system, it causes an increase in heart rate, an increase in velocity at which the action potential that is going to create that heart rate will be propagated, and an increase in contractile function. And there's the beta-2 receptor, which is going to cause smooth muscle cell relaxation or vasodilation. So if we give a drug that we say is an adrenergic drug, adrenergic is synonymous with sympathetic or sympathomimetic. Mimetic means to mimic. So adrenergic, sympathomimetic, and adrenergic agonists all basically mean the same thing. It means that they're activating or mimicking a response of the sympathetic nervous system. So for example, if we give epinephrine to a person, epinephrine is a adrenergic agonist. It's a sympathomimetic that binds to alpha-1, beta-1, and beta-2 receptors. We expect an increase in heart rate, an increase in contractile function, and vasodilation in certain areas. Now the reason why I say certain areas is epinephrine binds to alpha-1 and beta-2 receptors. Alpha-1 causes vasoconstriction, beta-2 causes vasodilation. So think about fight or flight. When we give epinephrine, somebody who needs to run or fight doesn't need to have more blood flow to their kidneys or their gut. So those areas are going to vasoconstrict to redirect blood flow more centrally to the heart. And in the beta-2 agonist section of that, we're going to vasodilate the muscles because you need muscles to run and to fight. And we're also going to relax the smooth muscles in the conducting airways because we need more blood flow there and we need them to be open. We need those lungs to be open. So epinephrine is an example of an adrenergic agonist or a sympathomimetic because it gives the effects we expect of the sympathetic nervous system. Now below that are four other terms: parasympatholytic, anticholinergic, cholinergic antagonist, cholinergic blocker. So all of these terms will inhibit the parasympathetic nervous system. And in doing that, we will get a response that's similar to the sympathetic response. So for example, if we give atropine, which is a parasympatholytic or an anticholinergic or a cholinergic antagonist or a cholinergic blocker, all these terms mean the same thing, this is going to cause an increase in heart rate by inhibiting the parasympathetic nervous system from slowing down heart rate. So in this situation, we get the expected sympathetic response by blocking the parasympathetic response. Now, if we go over to the other side, same thing is happening with the terminology, cholinergic or parasympathomimetic or cholinergic agonist. These terms all mean the same thing. That means they're activating the parasympathetic receptors. They're mimicking a parasympathetic response. So the one you're most comfortable with probably from hopefully last semester are the muscarinic receptors. You probably learned that muscarinic receptors in the lungs, muscarinic 3 in particular, will cause smooth muscle cell contraction and bronchospasm. Same thing happens in the blood vessels. In the heart, the muscarinic 2 receptors will cause the heart rate to slow down and for contraction to decrease. So if we give a drug that is cholinergic or a parasympathomimetic or a cholinergic agonist, we expect the heart rate to go down, contractile function to go down, and smooth muscle cell contraction to occur. Now under that, we have the opposites. Sympatholytic, again, lytic meaning to break or inhibit, anti-adrenergic, adrenergic antagonist, adrenergic blocker. So if we give a drug that inhibits the sympathetic nervous system, then we would expect the parasympathetic nervous system response or activity to occur. So just get comfortable with these terms so you know that they all kind of mean the same thing, but you'll see them used interchangeably. Okay, I apologize for my coughing. I still have this cold I haven't gotten over. Okay, so we talked about the sympathetic nervous system side, and let's move on to the parasympathetic nervous system side, or the cholinergic side. Again, we have the preganglionic nerve releasing acetylcholine that's going to bind to the postganglionic nerve, eventually resulting in this acetylcholine binding to the muscarinic 2 receptor in the heart. And in this situation, we're going to have a decrease in inotropy, chronotropy, dromotropy, and lusotropy. So when we say something has a positive inotropic effect, it means that it's increasing contraction. If we say it has a negative inotropic effect, that means it's decreasing contraction. If we say something has a positive chronotropic effect, that means it's increasing heart rate, or the rate at which an action potential is generated. And then dromotropy, if we say something has a positive dromotropic effect, it means that we're increasing the velocity at which that action potential generated will be propagated from the SAAB nodes to the myocardium to actually produce that contraction. And if we talk about lusotropy, so if something is a positive lusotropic drug, that means that it increases the rate at which that cardiac muscle can relax. And we'll talk more about that later. Okay, this slide illustrates what's happening at the smooth muscle cell level. So again, we have our sympathetic and parasympathetic neuronal pathways. On the sympathetic side, we are releasing acetylcholine from the preganglionic nerve, which eventually is going to result in the release of epinephrine from the adrenal medulla and norepinephrine from the postganglionic nerve. This epinephrine and norepinephrine are going to bind to the beta-2 receptor and the alpha-1 receptor. Both of these have opposite effects. So binding to the beta-2 receptor will cause, in an agonistic way, so norepinephrine and epinephrine are beta-2 adrenergic agonists. When they bind to the beta-2 receptor, they're going to cause smooth muscle cell relaxation. But this is going to be in areas that help you fight or flight, so areas that will improve oxygen transport. So the conducting airways of the lungs, the pulmonary vessels of the lungs, the muscles are going to experience smooth muscle cell relaxation to open up those blood vessels. But areas that we don't need, this epinephrine and norepinephrine are going to bind to the alpha-1 receptors, like the kidneys and the gut. We don't need those to run and fight. When that happens, smooth muscle cell contraction will occur, decreasing blood flow to those areas, and this basically redirects it to the areas that we need, such as the lungs and the heart and the muscles. On the other side of this, we've got acetylcholine being released from the parasympathetic preganglionic nerve and released from the postganglionic nerve, binding to the muscarinic 3 receptor and the muscarinic 2 receptor. When it binds to the muscarinic 3 receptor, excuse me, then it's going to produce smooth muscle cell contraction and glandular secretion. However, when it binds to the muscarinic 2 receptor, that's going to play a role in inhibiting the beta 2 receptor. So therefore, any agonistic effect on the beta 2 receptor would be inhibited. So we've got a double effect there. Now, baroreflex receptors, or baroreflexes, play a huge role in regulating cardiovascular mechanics on a short-term level. So if something acutely is happening, it's going to be the baroreflexes, or what I like to call the baroreceptors, that are going to play a role in regulating blood pressure to meet metabolic demands at that particular moment. So these are short-term blood pressure regulators. Now, in the picture to the right, you can see these yellow dots everywhere. These are representing the systemic baroreceptors, which I like to call mechanoreceptors, because they're going to experience changes in their shape as pressure and stretch changes occur in the blood vessels. And while they're experiencing these changes, they're going to be discharging signals. They discharge these signals with each pulse. So when we use the term baroreflex, we mean that we are increasing signaling to decrease sympathetic tone. So a baroreflex increases signaling to decrease sympathetic tone. So basically a negative feedback mechanism. So a decreased signal will cause an increased rate and pressure. An increase in signal will decrease rate and pressure. And as you can see in the figure to the right, they're located in the aortic notch, and this particular baroreceptor set will respond to increased and decreased pressure. They're located in the carotid sinus, and these baroreceptors are going to respond to increased and decreased pressures as well. But they're also located in the systemic arteries, where they're basically going to respond to high pressure. They're located in the systemic veins, pulmonary vessels, right atrium, and both ventricles. And in these situations, they will respond to low pressure. So think of baroreflexes as being caused by baroreceptors, which are actually mechanoreceptors, that will experience a change in shape based on the changes in volume, pressure, stretch in the blood vessels to indicate to the brain, okay, we need a higher rate because the volume is low or the stretch is low. We need a lower rate because the stretch is too high or the volume is too high. Short-term blood pressure regulation. Same thing happens with contractile force.
Okay, so this table represents a summary of the cardiac responses that will occur when the baroreceptors or the chemoreceptors, which we haven't really talked about yet, come into play. So if the stimulus at the baroreceptor level is a decrease in stretch, this is going to result in a decrease in parasympathetic tone and therefore a decrease in muscarinic 2 activation The outcome of this will be an increase in cardiac rate and an increase in contractile force, ultimately increasing cardiac output. If, on the other hand, that stretch is increased, then there's going to be an increase in parasympathetic tone, an increase in muscarinic 2 activation, decreasing cardiac rate and contractile force, and therefore decreasing cardiac output. On the chemoreceptor side, if we have a decrease in PaO2, an increase in PaCO2, hydrogen ions, and lactic acid, this means we need more perfusion. There's going to be an increase in sympathetic tone. This is going to activate the beta-1 receptors to increase contractile force and cardiac rate, ultimately increasing cardiac output. If the opposite is occurring, there's an increase in PaO2, a decrease in PaCO2, hydrogen ions, and lactic acid. Sympathetic tone will be decreased, decreasing beta-1 activation, decreasing cardiac rate and contractile force, and ultimately decreasing cardiac output.
Okay, so let's start with flow. In this situation, we'll talk about cardiac output as flow. Cardiac output is the amount of blood that circulates through the body in 1 minute, and normal, depending on the size of the person and their activity, is 3.5 to 8 liters per minute. Cardiac output is the product of stroke volume and cardiac rate. Stroke volume is the amount of volume ejected with each beat. And stroke volume is very, very dependent upon 3 major factors: preload, afterload, and contractile function. Preload is the filling pressure. So it's how the myocardium expands and accepts volume and the pressure that's generated during that process. It's very dependent upon venous return, and it's also very dependent upon ventricular and pericardial compliance. So the myocardium and the pericardium have to be able to stretch and expand to accept that volume. Importantly, it's not a volume measurement. End diastolic volume is the volume measurement. Sometimes preload and EDV are confused. So keep in mind that preload is a pressure measurement. It's a stretch pressure generated as the ventricles expand with blood. Afterload is the resistance the myocardium has to do to eject blood. So it's basically vascular resistance. That's what it is. So it's dependent upon vascular resistance. So example, the size of the blood vessels, the radius, the viscosity of the blood, etc. Also keep in mind it is not a volume measurement. In systolic volume, that should be an S and I'll fix that. In systolic volume is a volume measurement, and often afterload and in systolic volume are confused. So keep that in mind. Afterload is a pressure measurement. It's actually measured in dynes, and it's vascular resistance. And then the third one, contractile function, is really the myocardial health, the ability of the myocardium to respond to an action potential. An action potential is that electrical stimulus that's generated and propagated, eventually landing on a myocyte to say, hey, we need you to contract. So it's dependent upon the health of the myocardium and biochemical balance, because all of that requires some biochemistry. When we talk about contractile function here, we want to talk about it independent of preload and afterload. And the reason that I say that is you'll learn that preload, the more preload there is, the better contractile function there will be. Afterload, the more afterload there is, the harder it is for the myocardium to eject blood. So we want to talk about contractile function here, independent of preload and afterload. And that's where we're talking about the myocardial tissue itself and the biochemistry at that myocardial tissue. So if I were an RT student, I would begin to brainstorm. What kinds of things will increase or decrease preload? What kinds of situations can increase or decrease afterload? What kinds of situations will increase or decrease contractile function? Think about that and be able to talk about it when we meet next. Okay, some other terms to be familiar with are cardiac index and stroke volume index. Cardiac index is used to normalize cardiac output measurements among patients, and I usually like to say clients, of varying body size. Cardiac index is equal to cardiac output over BSA, and it's normally between 2.5 to 3.5 liters per minute per meter squared. A value between 1.8 and 2.5 liters per minute per meter squared indicates hypoperfusion. Anything less than 1.8 may be indicative of cardiogenic shock. Stroke volume index is used to normalize stroke volume measurements among patients of varying body size. Stroke volume is equal to stroke volume divided by BSA, and normal is between 33 and 47 mils per meter squared. Make sure you guys could calculate stroke volume if you were given cardiac output and cardiac rate. We're going to talk a lot more about cardiac rate when we have our meeting. Some other terms, as I mentioned before, is EDV, end diastolic volume. This is the volume in the ventricles at the end of diastole before systole occurs. ESV, end systolic volume. This is the volume in the ventricles at the end of systole after contraction. So these are the two terms that are often confused with preload and afterload, but it's important to recognize that they're very different measurements. Ejection fraction, often referred to as EF%, is the percentage of EDV ejected as stroke volume. So the calculation for it would be EDV minus ESV divided by EDV, or simply stroke volume SV divided by EDV. So often when we're talking about preload, we like to refer to Frank-Starling's law. In this particular slide, Frank-Starling's curve. In figure A, this is illustrating the relationship between stretch induced by end diastolic volume. So as we fill the ventricles with volume, you can see this blue line in figure A increase. And that increase is representing an increase in volume causing an increase in contractile force. But of course, there's a threshold, like I mentioned before. If we have just the right amount of myosin-actin associations, we're going to have a really strong contraction. But if we keep filling the ventricles and we pull those myosin-actin heads apart, that's when we lose that contractile force because we don't have as many myosin-actin associations. If we look at figure B, this is demonstrating the relationship between stroke volume, left ventricular volume, and left ventricular pressure. So you can see that as left ventricular volume increases, the left ventricular pressure also increases, but there's a threshold. Stroke volume seems to be optimal when that volume and pressure have a certain relationship. But afterwards, that stroke volume actually begins to decrease, as you can see with the pink depiction here. So we always want to keep that left ventricular volume, left ventricular pressure optimal so that we're maintaining a good amount of myosin-actin associations without pulling them further apart or pulling them apart. It's kind of like extending a muscle, if you will. So let's talk a little bit more about preload. As mentioned before, preload can be defined as the initial stretching of the myocardium, or here we'll say cardiac myocytes, prior to contraction. So, for example, when venous return is increased, the end diastolic pressure and volume, end diastolic volume of the ventricle are increased, and that's going to increase the preload. So the more the preload, the higher the preload, the more the stretch, the more effective stroke volume is going to be. And why is that? Well, there has to be adequate stretch for the myosin and actin of the cardiac sarcomere to come in contact with each other. But there's a threshold, because if this occurs too much, the stretching occurs too much, then these interactions that can occur will actually become disconnected, And then instead of having these strong myosin-actin connections, there's going to be less of them, and then the myocardium becomes floppy. So it is possible for us to exceed that stretch threshold. For example, if we have a person in the hospital that we are giving a lot of fluids to, and we give them too much fluids, we can actually cause the myocardium to stretch and exceed that threshold for effectiveness. And that's when we are inducing heart failure. So clinically induced heart failure by stretching the myocardium too much with fluid. So when we look at this figure, what you see here is a cardiac sarcomere, and you're looking at tropomyosin and actin. You can see them depicted here as the gray line and the orange beads. On this actin and tropomyosin is what we call a troponin complex, and you can see it represented here as TNC. You can see it as yellow, green, and purple. It's a 3-molecule complex. Well, when calcium binds to that complex, and you can see that up here at the top, it's going to cause a conformational change, kind of pulling that troponin, and in doing so, it's actually going to pull this actin-myosin association in such a way that the G spot, which is on the tropomyosin, the actin-tropomyosin complex that the myosin head wants to bind to, it's going to expose that. When this exposure occurs, the myosin is going to bind to that. And there's going to be a lot of processes that occur, but particularly the hydrolysis of ATP is going to cause that myosin and this troponin-actin complex to kind of pivot, and it's that pivoting that causes contraction. Now, when contraction is over, calcium needs to be released from this troponin complex so that it moves back to where it was, so that relaxation can occur. If that doesn't happen, if calcium is in too much concentration, so there's a lot of calcium binding to the troponin, then we can experience a state of tetany in which the myocardium actually doesn't relax completely. So in this particular picture, you're seeing how calcium is important to bind to the troponin complex, and in doing so, it causes a conformational change in that troponin complex, changing the association of tropomyosin and actin, exposing the G spot on the actin in the tropomyosin complex that the myosin wants to bind to, and then ATP hydrolysis occurs, allowing that myosin head to kind of pivot, and that pivoting, that sliding motion causes the contraction. And then when that's over, that calcium must be removed. In this picture, you can see that calcium comes from the outside of the cell, extracellular calcium, and as calcium comes into the cell, it actually instigates the release of calcium from the sarcoplasmic reticulum, the intracellular calcium. So there are electrochemical processes that kind of increase calcium to go into the cell and come out of the sarcoplasmic reticulum. But there are also processes that will help the calcium go back into the sarcoplasmic reticulum and out of the cell. And this is a dynamic process. Entering the cell causes contraction, exiting and being sequestered into the sarcoplasmic reticulum cause relaxation. So both are very much a biochemical process. I know a lot of times we think about systole or contraction as being active and diastole, relaxation, as being passive, but it's actually not. There have to be chemical processes that occur to actually allow the myocardium to relax, and that's very important to understand. Now remember, afterload is really vascular resistance. It's the work the myocardium must overcome to eject blood, and it's very much dependent upon vascular resistance. And this figure demonstrates the effect of afterload on stroke volume and left ventricular end diastolic pressure. So if we look at, excuse me, a decrease in afterload, which is the top dotted line in this figure. If we have a lower afterload, we've got more stroke volume and less left ventricular end-diastolic pressure compared to what would be baseline. And in that situation, we've got the optimal stroke volume and the optimal left ventricular end-diastolic pressure. But as we increase the afterload, increase vascular resistance, then the stroke volume decreases, even though the left end-diastolic pressure begins to increase. And it's a situation like this that can cause myocardial remodeling, because it has to work a little bit harder to eject that blood. And over time, when a tissue has to work harder, it has a higher metabolic demand, and it has to remodel to meet that metabolic demand. Sometimes that's good, sometimes it's bad. A lot of times it remodels to try and be more efficient. So in discussing afterload, we have to revisit this awesome equation. And what we can see from this figure is that they changed the equation around so that we could talk about how flow is affected and how resistance is affected. So flow is going to be directly proportional to the change in pressure or the driving pressure, but it's going to be inversely proportional to resistance. And resistance is going to be directly proportional to the, excuse me, to the length of the tube, but most importantly, inversely proportional to the radius of the tube. So the smaller the tube, the more resistance there is. So when there's a smooth muscle cell contraction, endothelial smooth muscle cell remodeling that causes it to be thicker or less compliant, all of these situations can cause an increase in resistance. Also, viscosity. If there's an increase in viscosity, then there's going to be an increase in resistance because it's harder to push that blood forward. So people that have polycythemia actually have an increase in afterload. So we want to think about these parameters so we could possibly modify them pharmacologically or otherwise to decrease resistance to improve flow. Okay, so let's talk about contractility. Contractility is the intrinsic ability of the myocardium to contract. And I want to add the ability of the myocardium to respond to action potentials or the electrical stimuli that it's receiving. It's dependent upon myocardial tissue health, calcium availability, and myosin-actin association. So any disease process that alters the histology of a myocyte and any part of this cardiac sarcomere can cause contractility to be changed. Now, myocardial histology is obviously a lot more complicated than what this presentation will share with you. But for simplicity, let's just talk about the different types of hypertrophy. On the top of this slide, you can see 3 purple circles, one representing a normal ventricle or ventricular chamber and the muscle mass that surrounds it. The middle represents concentric hypertrophy, and that means the muscle is basically thicker. So the volume in that chamber is decreased, but the compliance of that chamber is decreased. In this situation, the myocardium would experience diastolic dysfunction because its ability to expand and accept volume is decreased. On the right side is a larger circle, but you can see the volume is increased, but the muscle mass is not. It's not proportionally increased. In this particular situation, we call this eccentric hypertrophy. And there will be systolic dysfunction, which means that the myocardium is bigger, not because it's thicker, but because it's more stretched out. So the myocardium now at this point doesn't have the same ability to contract and eject blood. There's a decreased elasticity, even though there's an increase in volume. Now, different types of myopathy. This is the bottom part of this slide. On the left, you see normal, and then the middle two represent hypertrophic, which is a concentric hypertrophy, and restrictive, which doesn't necessarily cause a hypertrophy. It's not necessarily larger, but the muscle tissue is fibrotic, if you will, and both of these situations have a decrease in compliance. So both hypertrophic and restrictive myopathies have a decrease in compliance, a decrease in the ability of the myocardium to expand and accept volume. This causes a diastolic dysfunction. When there's diastolic dysfunction, that means the volume load is not going to be adequate to produce that good myosin-actin association, and therefore the stroke volume will be decreased. On the right side is dilated myopathy. And this is similar to the eccentric hypertrophy on the top. And in this situation, we've got a stretched out, floppier myocardium. And so instead of having the inability to expand and accept volume, it has the inability to retract back or contract to produce a good systolic function. All right, so myopathies and hypertrophies can change contractility or contractile function, but also the presence of ischemia or injury or infarction in the myocardium can also change contractility. So ischemic tissue does not contract well, and it's also electrically irritable, so it's more prone to dysrhythmias. Injured tissue is the same. It's just a little bit worse. An infarcted tissue does not conduct electricity at all, and it does not contract at all. So when we're looking at ischemic tissue, if we don't deal with that ischemia, if we don't improve the blood flow, for example, get rid of the blood clot that's formed or open up the atherosclerotic lesion, then that tissue is going to become injured. And injured tissue will either experience improved perfusion and therefore decide, based on internal chemical stimuli, whether or not it will remodel to be able to deal with this insult later better, which can cause hypertrophies or myopathies, or it will die, and that's what an infarction is. So infarction is necrotic tissue. It's dead tissue. How do we recognize these three different changes? An EKG really is the best way to do that, even though it's not 100% foolproof. So somebody can experience myocardial ischemia, injury, and infarction and still have a normal-looking EKG. But usually what we'll see in the presence of ischemia only, we will see ST segment changes. So you can look at the top EKG complex. You have P, Q, R, S, and T. Ischemic tissue might present with an inverted T wave, which you can see here, or ST segment depression. And I've drawn a line here representing the baseline. The ST segment would be the segment between the S wave and the T wave. At the top, you can see how that section of this complex is below the baseline. That's what we call ST segment depression, and it's most commonly indicative of ischemia. It can be caused from other things too, but for here, for this situation, we'll just talk about it in regards to ischemia. If we look at the infarcted ECG complex, you can see that that ST segment is above the baseline, and that's commonly indicative of what we call injury. When you're looking at an EKG, you can't necessarily say it's infarction. We usually have to say injury pattern, because infarction is something that really has to be determined via an echo. When you do an echo and you see akinesis, no movement, that means that there is infarcted tissue. But an EKG is not that specific. Now, if we look down at the third EKG complex, you see this huge Q wave relative to normal size. Often, but not always, necrotic tissue will present with a pathological Q wave. And that means it's a Q wave that's deep and wide compared to what is normal. And you'll learn more about this in EKG. If you want to learn more about it, go ahead and look at my EKG videos that are at the bottom of Canvas. So again, myopathies, hypertrophies, myocardial ischemia, injury, and infarction all can impair contractile function and therefore decrease stroke volume. Okay, so now that we have the basics of short-term blood pressure regulation under control, I just want to mention long-term blood pressure regulation or control. And that really happens at the kidney level. So when the kidneys recognize hyperosmolarity in the blood, or there's signals from the atria, from decreased atrial receptor activity, the baroreceptor activity we were talking about earlier, sympathetic stimulation, or hyporenal perfusion, the kidneys are going to say, hey, I need more blood flow. So something's going on, something's not right. And what the kidneys are going to do is increase what we call renin. And renin is going to be transported to the liver. And in the liver, renin is going to cleave what we call angiotensinogen to angiotensin 1. And then that angiotensin 1 is going to be transferred to the lungs through the bloodstream. And in the lungs, angiotensin 1 will be cleaved to angiotensin 2 by what we call ACE. So I'm sure you guys have heard of ACE inhibitors before. Angiotensin converting enzyme is ACE, and that cleaves angiotensin 1 to angiotensin 2. And angiotensin 2 does a lot of things. Excuse me. One thing it does is cause smooth muscle cell remodeling. And when it does this, this decreases the compliance of the vascular, the arterioles. And when it causes this remodeling and decreases the compliance, it also decreases their ability to respond to endogenous catecholamines like epinephrine, norepinephrine that cause smooth muscle cell relaxation. So over time, what this results in is hypertension or an increase in afterload. Now, angiotensin 2 also goes to the pituitary gland and plays a role in increasing the release of vasopressin, which you guys know as antidiuretic hormone, from the posterior pituitary. And vasopressin does two things. It all by itself causes vasoconstriction to increase arterial pressure, but it also increases renal fluid reabsorption in the convoluting tubule of the kidney. And this causes an increase in blood volume. An increase in blood volume is going to cause an increase in arterial pressure. Now, angiotensin 2 also goes to the adrenal gland, and it increases the release of aldosterone. And this increase in aldosterone will increase the sodium chloride pump function in the kidneys. This is also going to increase renal fluid reabsorption, increasing blood circulating volume, and increase arterial pressure. So in this situation, what we're seeing is the renin-angiotensin system increasing blood pressure by causing smooth muscle cell remodeling, making them less compliant and less responsive to endogenous smooth muscle cell relaxers like epinephrine, causing vasopressin release that causes vasoconstriction and increase in renal fluid absorption, and increases aldosterone secretion from the adrenal gland that also is going to result in an increase in blood volume. So this is a perfect example of how one system can be systemic. So here we've got the heart, the kidneys, the liver, the lungs, the hypothalamus and pituitary gland, the adrenal gland, all working together to regulate blood pressure. So this is a perfect example of how we can never take one system and make it stand alone. So the lungs never stand alone. They're always working together with everything else. Heart never standing alone, always working together with everything else. Now on the flip side of that, we have the anti-natriuretic peptide effects on long-term blood pressure regulation. And again, this is where we're looking at these baroreceptor reflexes. So when the myocardium experiences atrial distension, sympathetic stimulation, too much angiotensin II, endothelin 1, then it's going to play a role in saying, hey, we need to decrease pressure, we need to decrease volume. And the overall effects are going to be the opposite of what you saw in the renin-angiotensin system. There's going to be a decrease in aldosterone. There's going to be a decrease in angiotensin II. There's going to be a decrease in renin. All of these are going to decrease volume reabsorption and decrease vasoconstriction, which are ultimately going to decrease atrial pressure, decrease blood pressure. So just pay attention to this figure and think about it a little bit. Now, it's also important to remember that, or understand that perfusion or blood flow to a tissue can be regulated by that respective tissue, independent of all the other things that we've talked about. So when a particular tissue increases an increase or a decrease in metabolic demand, it's going to cause a secretion of different biochemicals that play a role in increasing or decreasing the lumen of a respective artery in its region. So for example, the smooth muscle cells will respond to vasodilators when there is a need for an increase in blood flow to support an increase in metabolic demand. And those vasodilators include nitric oxide, bradykinin, histamine, certain prostacyclins, and prostaglandin D2 and E2. These will cause that smooth muscle cell to relax and open up so that the blood vessel in that particular local area will be able to provide more blood flow, more perfusion, to provide more oxygen to support local metabolic demands. And the opposite is true. The vasoconstrictors, endothelin 1, acetylcholine, thrombin, platelet activation, and oscillatory shear stress will cause those smooth muscle cells to constrict and decrease blood flow. So in summary, understanding the blood flow through the heart, lungs, and body is useful for interpreting signs and symptoms related to heart failure. Inadequate perfusion can result in tissue hypoxia and lactic acidosis. The radius and length of a blood vessel, blood viscosity, driving pressure, and flow, or what we might call cardiac output, ultimately determine tissue perfusion. Cardiac output is the product of stroke volume and cardiac rate. Stroke volume is determined by afterload, which is vascular resistance, preload, which is ventricular stretch pressure, and contractility. The autonomic nervous system is responsible for short-term cardiac output and blood pressure regulation. The renin-angiotensin system and anti-natriuretic systems are responsible for long-term cardiac output and blood pressure regulation. Tissues can regulate their own perfusion independent of the autonomic nervous system through autoregulation at the endothelial and smooth muscle cell level. Okay, now that we got the physio out of the way, let's talk about some hemodynamic measurements. The measurements we're going to talk about can be obtained through three types of catheters. The arterial catheter, or what we call the A-line, the central venous catheter, or CVP, and the pulmonary artery catheter, or PAP. Some useful physical principles to keep in mind while we go through this discussion are liquids are non-compressible. Pressures at any given point within a liquid are transmitted equally. This is Pascal's principle. When a closed system is filled with liquid, the pressure exerted at one point can be measured accurately at any other point on the same level. And some equations are applied to the systems that we'll be talking about, even though I won't expect you to be doing this. Just think about it from a practical standpoint. Pressure is equal to force divided by area. Force is equal to pressure times the area, and area is equal to the force divided by pressure. Okay, an A line or an arterial line is a line that's placed in an artery that will include a transducer for the purpose of being able to measure pressures. So it is placed in the brachial or radial artery, facing the flow of blood, and then it's connected directly to tubing that's filled with liquid. The pressure that's exerted by the blood at the tip of the catheter that's in the artery will be accurately transmitted to the liquid-filled tubing where it can be measured using the transducer. So why do we use an A-line? We like to use it to measure systemic artery pressure, so blood pressure. If somebody is in ICU and they need repeated blood gases, ABGs, then we can draw ABGs from an A-line. And some places will actually use it to measure cardiac output, even though this is not super common. It can be placed in the radial, brachial, femoral, dorsalis pedis, umbilical arteries in the neonate. But the radial artery is preferred given that there's collateral circulation. And when you learn blood gas sticks, you'll learn that radial artery is also preferred for that. And you'll do Allen's test to determine whether or not there is indeed collateral circulation. Position. To ensure the accurate measurements, the transducer, catheter, and the measurement site should all be at the same level. So go back to those physical principles we talked about. If the transducer or catheter is higher than the site, then there will be a false low pressure reading. If the transducer or catheter is at a lower position than the site, then there will be a false higher pressure reading. Some complications that would occur with an A-line would be ischemia if a thrombus or embolus occurs in the catheter, vasospasm, and this would be evidenced by a pallor distal to the insertion site and usually accompanied by pain and tingling. Hemorrhage if the tubing is disconnected or the stopcock in the system is not closed, and or of course infection. Now once the A-line is in place and you get a good waveform, this is what it looks like. So first of all, think about blood pressure. We're going to be able to get blood pressure from the waveform. Normal systolic blood pressure is between 90 and 139 millimeters of mercury. Normal diastolic blood pressure is between 60 and 90 millimeters of mercury. To determine the mean arterial pressure, MAP, we take the systolic pressure plus 2 times the diastolic pressure and divide it by 3. This is a key parameter for determining whether or not we possibly have good perfusion. Now, in this particular formula, diastolic value receives a greater weight because the diastolic phase is about twice as long as the systolic phase. When we're calculating MAP, a MAP of 60 is considered the minimum pressure needed to maintain adequate tissue perfusion. So let's look at this graph. On the left side, the y-axis, you can see the pressure measurement, and this is the arterial pressure or blood pressure. On the x-axis, you see time. When we look at the very first part of the waveform, it goes down. This is representing diastolic pressure, and you can see that represented as DPP, DBP. As it continues up and peaks, you can see SBP, which represents the systolic blood pressure. As that waveform comes down, you see there's a notch, and they call it a dicrotic notch, which represents the closure of the aortic valve and the start of diastole. So you can see it continue to go down until we reach that bottom wave, and then it goes back up to systole. Okay. when you see the very bottom part of diastole, right before we peak to systole, you see an arrow that represents AVing, the aortic valve opening. It has to open in order for us to inject blood into the aorta. That means that there's contraction happening. The pressure in the ventricles is increased relative to that's in the aorta, and that causes the AV node to open. And you can see the pressure increases as blood enters the aorta, and then you can see that dip down, that dicrotic notch representing AV closure, the aortic valve closure, and you can see that pressure decrease as we enter the diastolic phase. So this is what an A-line waveform looks like. Now, questions for you. What causes an increase or decrease in arterial pressure? What about pulse pressure? What is pulse pressure? How can we get it from this particular waveform, and why do we care about it? Okay, moving on to central venous catheter. But really, a lot of times the CVP catheter is part of the Swan-Ganz catheter, which is what you see on the right side here, the pulmonary artery catheter. But sometimes they won't be used to necessarily do the more invasive measurements that occur in the heart and the pulmonary artery. So that's what we're talking about here, is simply measuring the central venous pressure. So the catheter is a multi-lumen catheter that allows the infusion of blood and various medications through different ports. It permits aspiration of blood samples, particularly mixed venous blood or venous blood, or it allows injections for cardiac output measurements without the interruption of medications. So CVP, central venous pressure, is the pressure of blood that's in the vena cava, but is often equal to the pressure in the right atrium and the right ventricle when the bicuspid valve is open. It's also referred to as right atrial pressure, right side preload, or right ventricular end diastolic pressure. So my question to you is, what are indications for a CVP line? What causes an increase or decrease in arterial pressure? What are potential risks associated with a CVP line? Okay, so this has the same picture because a pulmonary artery catheter or a Swan-Ganz catheter will also have a CVP port. So if we look at that figure to the right, port number 1 is what we call the proximal port. We'll talk more about that later, but it also plays a role as the CVP port. So a Swan-Ganz catheter is important for monitoring other things that are not as easily monitored, such as cardiac rate, blood pressure, and CVP. Measuring these often does not provide accurate or timely data for correct management of critical cardiopulmonary problems. So it's used to monitor pulmonary artery pressure, right and left heart function. It also uses a flow-directed balloon-tipped catheter that plays a role in where the position of that catheter and transducer is going to be. It has a number of variations. However, it's typically 110 centimeters in length, has 3 to 4 lumens, and the exterior of the catheter is marked off in 10 centimeter segments used to estimate catheter tip upon location when it's inserted. Okay, so let's look at this catheter a little bit more. So the proximal lumen lies in the right ventricle, and this measures central venous pressure. It can be used to inject medications, aspirate blood samples, venous blood samples, and it can be used to inject thermal bolus for thermal dilution cardiac output measurements. The distal lumen lies in the pulmonary artery. It measures pulmonary artery pressures. It can be used to aspirate mixed venous samples and continuous monitoring of SpO2. And it also can be used to inject medications. The thermistor port, this is a temperature sensing device, It's used during thermodilution cardiac output measurements, and it also measures core temperature. The balloon is about 1.5 cc's in volume when it's at its max volume, and this is used to help float the catheter into place. So my questions to you: what are indications for a pulmonary artery catheter? What causes an increase or decrease of each pressure measurement that we're going to talk about in the next slide? And what are potential risks? All right, so here is a picture that demonstrates the waveforms that can be generated from a PA catheter as it moves through the heart. So on the left side, you can see the red catheter and balloon in the right atrium. And this is the same as CVP pressure for the most part. And normal right atrial pressure is between 2 and 6 millimeters of mercury. And you can see that pressure down at the bottom represented, it looks like about maybe 2.5 to 5 millimeters of mercury relative to the heartbeat at that time. And if we move on towards the right, you can see that catheter balloon is moved into the right ventricle. The right ventricle is significantly smaller in mass to the left ventricle because it doesn't have to push blood out to a whole systemic area. It just has to push blood out to the pulmonary vessels, so it doesn't need to be as big. And its pressure, systolic, is average between 20 and 30 millimeters of mercury, and diastolic 0 to 5 millimeters of mercury. And you can see that represented as the waveform, the second set of waveforms, showing a pressure that increases to about 28 and going down to maybe about 1. As we move that balloon and catheter into the pulmonary artery, again, there's going to be a systolic and a diastolic pressure here because the pulmonary artery is going to be able to experience accepting volume from that right ventricle and also retracting back to its resting state, which will be diastolic pressure. So normal is 20 to 30 and 5 to 15. And you can see that that pressure is represented in the third group of waveforms. And in this particular picture, it looks like it's about 27, 28 systole, and diastolic looks like it's maybe around, let's see, 16 millimeters of mercury. Moving forward, if we continue to push that catheter forward and wedge it into the pulmonary artery and occlude the flow going through that pulmonary artery briefly, we can get an idea of what's happening in the left ventricle. So when the mitral valve is closed, we're getting a primary idea of what's happening in the left atrium. When the mitral valve opens, then we're getting an idea of what might be happening in the left ventricle. Normal pulmonary capillary wedge pressure is between 4 and 12 millimeters of mercury. And if you look at this picture here, this PAOP is representative of pulmonary artery occlusion pressure, which is really the same as pulmonary capillary wedge pressure. And in this particular picture, still looking at the waveforms represented by PCWP, the occlusion pressure or pulmonary capillary wedge pressure is equal to the peak, which is P, plus the valley, which is Q, divided by 2. So take a look at this and get an idea of the normal pressures that occur in each part of the lung and ventricles that we can actually measure. And I'd like to know, what can increase or decrease right atrial or CVP pressure? What can increase or decrease right ventricular pressure? What can increase or decrease pulmonary artery pressure? What can increase or decrease pulmonary capillary wedge pressure? So this is your, I don't want to say formal homework, But homework to be thinking about so that we can talk about this on our next meeting. Hey, in summary, arterial lines are used to monitor blood pressure, obtain ABG samples, and indirectly measure cardiac output. The arterial waveform offers information about blood pressure and the cardiac cycle. A pulmonary artery catheter or Swan-Ganz catheter can be used to measure pressure in the right atrium, right ventricle, pulmonary artery, and indirectly measure left heart function using pulmonary capillary wedge pressure. The pulmonary artery catheter measurements offer information about volume status, cardiac output, right and left heart function, pulmonary artery function, and mixed venous sampling. So normally when we write SVO2, there should be a line above the V and a line above a letter represents an average. So that's where the mixed venous comes from. And that line is just not lining up, so I apologize for that.